Welcome to the third session of our conference, AI and COVID-19. This third session is entitled Tracking the Epidemic. We're going to talk about technologies that are being used or developed or imagined for tracking this epidemic. We have an exciting lineup of speakers, and we're going to go right into it. The first speaker is Dr. Jason Wang. Jason is from Stanford University, and the title of his talk is Taiwan's Use of Data Analytics to Control COVID-19. Jason, now is a good time to share your slides and your thoughts.
So just wanted to give a little context here. So Taiwan is a democratic country about 81 miles off the coast of China. In January this year, it had its presidential election, and where 75% of the people voted. So this talk is about Taiwan's response to COVID-19 based on a JAMA paper. And you can look at for details. There are 124 action items that's described in the paper. So after SARS in 2003, Taiwan has been thinking about how to prepare for the next epidemic. And so it had passed a series of amendments to its Communicable Disease Control Act. That includes trying to keep track of all the protective equipment stockpiles, setting up a National Health Command Center for coordinating government agencies, putting together a set of regulations for gathering, entry, and exit of people and traffic. Also amend the law so that there's penalties for violating home quarantine and isolation. And then, for the purpose of this talk, a set of laws to track and manage people under infectious risk, and also allows geographic location and total number of patients to be made public in an aggregate manner. And then finally allows the public property, including military camps and so forth, to be used and facilities to be made for essential equipment. So here is the Taiwan's National Health Command Center. So as you could see, it has a room for different data analysts to get the data from different local and state national governments and internationally. It has a media room to report to the public what they're doing, and you could also sleep there because it is a lounge. So it's a 24/7 operation that could host 100 people. So this is what it looks like, and this is what's happening right now. From the data, they have a national health insurance stockpile system, the National Health Insurance Infectious Disease Statistics System, and the media surveillance system, all in the command center. So the first thing that Taiwan did this time was to recognize the crisis. And so immediately after December 31st, when there was a report of a suspicious coronavirus coming from Wuhan, Taiwan immediately sent people onto the airplanes that were coming from Wuhan to check for their symptoms. And on January 20th, they activated the command center and had a national security meeting convened where all the ministries are supposed to act really quickly. So this is how they do it. They boarded the flights to make sure that people won't bring in and having fever and coming into the country without being checked, because there was suspicion of human-to-human transmission. So when people landed, what they did was they scanned a QR code. The QR code would lead to an online declaration form. And an online declaration form, you fill out your travel history, where you have been in the last 14 days, and if you've been to a hotspot area or not, no. And also you fill out your symptoms, cough, respiratory symptoms, or signs of fever. Then you fill out your cell phone number and the place that you're staying in Taiwan. So if you didn't travel to a level 3 alert country, like if you didn't come from Wuhan or in later on South Korea, you will get a SMS sent to your phone that says you passed, so you could go quickly through customs. Now, if you went through high alert countries, level 3 countries, you need to do a 14-day quarantine. So during the 14-day quarantine, they will bring you food. They will track you to make sure you didn't go outside and to make sure that you didn't get on the metro and infect other people. And then later on, they start paying people under quarantine with the daily wages equivalent to GDP per capita. What they also did was they linked the National Health Insurance database with the Customs and Immigration database, so that when the doctor sees a patient in clinic, the doctor will be alerted, or the nurse will be alerted that this person has traveled to Wuhan. So then they will be putting on protective gear. They will triage them separately, and then they will have index suspicion for COVID-19, and then order a test if it's necessary, if they believe that there's enough evidence that this patient might have that. So this way, they allow them to quickly get at the people through their system. So this is a picture of the alert at the point of care when a doctor sees a patient coming from level 3 alert countries. What they also did with the data is that they immediately got a quick count of the nation's stockpile. So on January 20th, they told people there are 44 million surgical masks, 1.9 million N95, and 1,100 negative pressure rooms. So what that tells people is people did a quick math, say, 44 million surgical masks. Taiwan has 23 million people. Well, that's less than 2 masks per person. So then the next day they said, well, we are going to ban mask exports to outside, and we have to make more. So then what they did was they got all the best engineers together to hack out 60 different supply lines, and they immediately got the raw materials necessary to make masks. So they increased the mask protection from 2.44 million units per day to now 11 million per day. And as of today, they are going to be donating masks to the United States. So this is what they did with the Diamond Princess cruise ship. So this ship actually went to Taiwan on January 31st before it went to Japan. When it got to Japan, they would discover that there were numerous cases. So people in Taiwan started to panic. So what the government said was that, okay, we'll give you the 50 places where the visitors from the Diamond Princess had been, and then they will send text messages to people who had been in that vicinity based on their cellular data. So that this is on the right, this is the text message they will get in. If you have been to the following places on January 31st from 6 a.m. to 5:30 p.m., you could check out this map and then call the number 1922. So the government will check on you. This is a map of the masks. So they created an app for people to track whether they could buy masks. And then even they have an inventory. The green is, if they still have 50% inventory. So the government for each store give them 600 masks per day to sell. So you could track the closest location to you to get the mask. They also monitor temperature for buildings. So if you walk in and you light up, then you can't get in without getting additional checks. Then they communicate with the public daily. The government now has 90% approval rating from the public for the handling of the crisis, and it's got the lowest per capita infection rate and death rate in the world. So they need to continue to monitor it. Most recently, they have people from the US and Europe going to Taiwan because it's safer there. There must be a balance between emergency power and maintaining civil liberties, which I'm currently working with Michelle Mello in the law school to do that, to better understand that. Basically, they've worked on logic and sequence and tempo, when to do things fast, and then articulate it to the public. And that's what they have done. Thank you.
Thank you very much, Jason, for that great glimpse of what happened and how it was managed in Taiwan. Our next speaker is Lucy Lee. Lucy Lee is from Chan Zuckerberg BioHub and is going to be speaking on tools for estimating unreported infections of COVID-19. Lucy, please share your slides, which I see you have, and take it away. Thank you.
I work on the data science team at the Chan Zuckerberg BioHub based in San Francisco. I'm particularly interested in combining pathogen genomic analyses with mathematical modeling and machine learning approaches to help understand the transmission of infectious diseases. So I'll spend the next few minutes talking not about the COVID infections that we observe, but rather those that we cannot detect, and discuss why it's important to quantify the number of undetected infections. So not all infections are detected by healthcare systems. This can be because the symptoms are too mild for the infected individuals to seek healthcare, or there's a limit on the number of tests that can be performed. or there could be restrictive criteria for selecting individuals for testing. Regardless of the reason, the consequence of a large number of undetected infections is that infections can spread latently through the population, which is a problem when those infections end up in vulnerable individuals. Furthermore, this also facilitates pathogen spread across large geographical distances when those infected individuals are able to travel when they are infectious. And lastly, when considering eliminating a disease from a region, it takes much longer to be certain that the disease is gone. So how can we estimate the number of undetected COVID infections? The most obvious solution is to do more testing, not just of symptomatic individuals, but of the population at large. I highlight here a few examples in Washington, in South Korea, and on board the Diamond Princess cruise ship. These methods are very useful for quantifying how many cases are asymptomatic or mildly symptomatic. However, this process is obviously very expensive and time-consuming and may not be doable when resources are already constrained. So besides trying to directly detect the usually undetected infections, we can use modeling to infer what those numbers are based on when and where infections occur. I highlight here a couple of examples of this approach to quantify the number of undetected infections, both of which found very low rates of detection based on early pandemic data. However, there's usually a great deal of uncertainty in modeling results at the start of a pandemic. Adding in additional sources of data can improve the accuracy and precision of estimates and reduce potential biases from single sources of data. So besides case count data, another source of data that is informative of the number of undetected infections is the virus itself. I link here a blog post by Trevor Bedford, the founder of NextStrain, who did some back-of-the-envelope calculations to infer how many undetected transmissions had occurred in Washington by March. So what information is contained in the virus that allows us to estimate the number of undetected? Let's assume for a moment that we're able to test every single individual and track every single transmission in the population. If we sequence the viral genome, we can see that it mutates as it transmits through the population. This is a process that happens to all living organisms. Every time DNA is replicated, there's a chance of mutation. The viral genome, after many rounds of transmission, starts to look different from the original virus that infected the population. Now, let's assume we are only able to test 1 in 4 infected individuals. If we know how quickly the virus mutates, we can infer how many missing transmissions could have occurred between the tested cases. So in my work, I modeled both the time series of case counts at the start of the epidemic, as well as the viral genomic diversity to quantify the number of undetected infections. The viral genomic data are represented here by a tree. Each tip on the tree represents a viral genome, and the closer the viral genomes are on the tree, the more related they are. So using just data from Hubei, the province in which Wuhan is located, I found that only about 1 in 7 infections were detected in the reported time series. Once adding in infections outside of China, that number was potentially as low as 1 in 20. This large number of undetected infections is in the same ballpark as what was reported in the other modeling studies I referenced earlier. This means that by the time 100 confirmed cases are in the community, there could be as much as 1,000 other infected individuals who are not symptomatic enough to be hospitalized and could transmit the disease undetected. This is why, in the absence of a vaccine, population-wide social distancing is needed to get the case numbers down. Since I started the analysis of this pandemic data, the epicenter of the pandemic has shifted to other parts of the world. So the next step in my work is to use this approach to quantify the undetected numbers in different countries and regions and elucidate what fraction of the undetected cases is due to mild symptoms versus limited testing capacity. Another implication of this large number of undetected infections is in the recommendation for face mask usage. So this article just came out in the New York Times that highlights the significant role that asymptomatic or mildly symptomatic cases play in continued transmission of COVID-19. And this may lead the CDC to recommend broadened usage of face masks in certain public areas, such as supermarkets. So before I finish, I wanted to highlight some of the other COVID-related work that is happening at the BioHub, which for those of you who are not familiar, is a nonprofit biomedical research organization based in San Francisco. So recently, the BioHub became one of the COVID testing labs, helping to expand the testing capacity in the Bay Area. In addition to diagnostic testing, we're also interested in a number of research questions involving the analysis of both pathogen and host data. So in the interest of time, I won't read out all of these names, but I want to make sure I acknowledge the contribution of these groups of people, as well as the research and medical communities globally who are coming together to improve our knowledge of this pandemic disease. Thank you.
Thank you very much, Lucy. Before I introduce our next speaker, I want to remind the audience online that they may submit questions on the main page for the conference. You'll see a link that says click here to join the conversation. You can submit questions, and then our team will be reading them and feeding them to us during the Q&A, which will be at the end of this panel session. Our next speaker is John Brownstein. John is at Harvard, where he studies methods for real-time mapping of COVID-19 cases worldwide. Thanks, John. I see that you're already sharing, so take it away.
All right, great. Thanks, Russ, and good to be here. I'm going to be telling you a little bit about a variety of our activities that we're engaged in right now as far as COVID surveillance. Obviously, it's all work in progress. So the idea here is just to give you a sense of the kinds of things we're actively doing and some preliminary results. We've been tracking coronavirus since the emergence event in late December. And this is just a graphic showing the data that we're collecting over time as it spread globally. And the reality is being able to create a visual and sort of a situational awareness of this kind of data is really challenging given the lack of sort of official sources. The earliest signs of what took place in China were actually through our data mining tool called Health Map, where we identified the early signs of the outbreak through mining in Chinese language and local news media, WeChat, Weibo, and highlighted the fact that you could use these tools to basically uncover what's happening in population. It's something that we've been doing for many years through many disease outbreaks. The reality is that the only way to create sort of a situational awareness view of what's taking place is through mining of all this information and collating it. What we quickly realized is that as much as it's easy to sort of scrape the web, to create a real detailed line list of cases around the world, you need sort of an army of people. It can't just be done through machine learning and web scraping. And so we created a network of organizations from Oxford, University of Washington, Northeastern University, many others, that essentially created a global line list of cases. So combing the web through official and unofficial reports, creating a detailed line list of every single case around the globe. And that becomes more and more challenging over time, clearly. But that ultimately now resides in a public site on Health Map. And that data is made freely available. And because that data was heavily curated and made available, it's generated a whole set of publications all aimed at forecasting and understanding sort of the risk in different populations, and especially understanding the efficacy of various interventions. This is a paper we just published in Science last week, which essentially utilized our line list data along with mobility data from Baidu. And because Baidu has highly granular data on population movements, we could connect movements to sort of case information. And as soon as interventions started coming into place, we saw the massive drop in cases that were taking place in China. So that's just one example of a way that once you built a really detailed case count, you can actually start to fuel a lot of both the science as well as policies related to interventions. We're doing this in a whole variety of ways, not just through data scraping, but through collecting data from the general public. This is our tool called Thermia, which is actually identifying fevers in populations through sort of a decision tree. This is something that we launched years ago and connected that to smart thermometers like the Withings Thermo device. But the reality is we actually already had in play a fever calculator in China at the time. And so what we were doing was actually collecting data, not just from official sources, but through people that were disclosing symptoms as well as temperature. And of course, we saw the bubbling up of case or symptomatic cases, which not necessarily confirmed across China at the time of the emergence. of COVID. So again, another good example of how the sort of collected data across the population can be incredibly valuable. We've extended that work with a number of different symptom checkers. This is a company called Buoy that we're working with. It's an AI-driven conversational chatbot that we have helped sort of customize for the purposes of COVID. And already this tool has been widely deployed and shows incredible diagnostic and triage accuracy. And so right now, this tool now has been made available for the state of Massachusetts and more broadly, where essentially the case definition for COVID has been entered. And so now anybody who has sort of, potential symptoms around COVID can go through this sort of conversational interface. On the other end, we're going to be collecting data from this tool to basically improve our surveillance efforts at the local level. A lot of our work is not just about sort of getting sort of the digital exhaust from patients, but it's also crowdsourcing. This is a project we launched actually 9 years ago off the movie Contagion called Flu Near You, where we engage people to answer a few questions and then essentially get a national army of people responding about symptoms across the country. And what's phenomenal about that is you can, for instance, look at the emergence of flu in a population very easily. We've now adapted this for COVID, so COVID Near You, which is now launched about a week ago. And this has been crafted to have specific symptoms that relate to COVID, as well as collecting testing data. Of course, clearly, we have a lack of testing across the country. So being able to have insights into patterns, emerging hotspots, can be driven heavily by individuals just contributing information. And so right now in the system, we have over 260,000 people now reporting symptoms and doing that at a fairly frequent clip. And so from that, we're now, of course, in the process of analyzing all this information, looking at demographic patterns, symptom patterns, connecting that to testing data, looking at contact tracing, and of course, lots of other opportunities as this emerges. We're actually expanding this to other countries at the moment. The last thing I'll just mention is it's not just about mining for case information and events and symptoms. We're working closely with the CDC to build tools to actually have understanding of social distancing impacts. So what are communities doing to prepare for coronavirus? There is no sort of unified data set to look at school closures or closures of various community events. And so we're pulling together all that policy information and events at the community level to then provide sort of a common operating picture for the CDC as they're trying to understand sort of the variation in sort of interventions that are happening across the country. And clearly being able to have that kind of data and matching that to epidemiological information will be super important to understand the efficacy of the various interventions. And we know that there's major variation across the country. Obviously, many places not had stay-at-home orders. Many places we're not seeing as much sort of adherence to sort of the general policies that have been put out. So being able to connect this kind of data with epi data, then we'll be able to do some of the same studies that we did for China. So I'll leave it there. Look forward to the discussion. And sorry again about the technical difficulties there.
Thank you very much, John. Really exciting stuff. Our next speaker will be Ryan Tibshirani. Ryan is from Carnegie Mellon University, and he'll be speaking on epidemiological forecasting tools for COVID-19.
Yeah, thanks for the intro. My name is Ryan Tibshirani. I'm a faculty in statistics and in machine learning at Carnegie Mellon University. I work with a group that Roni Rosenfeld and I co-lead at Carnegie Mellon called Delphi. We are one of the CDC's 2 centers of excellence for flu forecasting. And I recently became an Amazon Scholar. So just a quick note before I begin. I am not a public health expert. I'm a statistician who has been thrown headfirst into what has been an exciting and a kind of extremely challenging effort in pandemic forecasting with the CDC. So just take that as my background as I describe kind of where I'm coming from and what we're doing. So first I wanted to just tell you a little bit about the efforts we've been doing for many years, which are very relevant to what we're doing now. We've been working on flu forecasting at Carnegie Mellon and the Delphi group for about 6 or 7 years. Influenza is a major global public health problem. It's associated with between 250 and 500,000 deaths each year, as estimated by the World Health Organization. And in the US, it's typically between 30 and 60,000, but we do have bad seasons, like, for example, the worst season in recent memory was the 2017-18 season, in which the CDC estimates about 80,000 flu-related deaths occurred. So as I mentioned, we've been doing this at Carnegie Mellon since about 2013. And interestingly, what prompted us to begin this was that CDC has at that year begun a forecasting challenge every year for seasonal influenza. There are about 40 systems that participate in recent years. Each one of these systems is put forth by typically an academic unit, but there are also some units in industry who participate. This is kind of completely community oriented. There's no compensation, obviously. We are all doing it for the purpose of advancing science. Why does the CDC care? They care because forecasts of seasonal influenza can help them essentially with preparedness and countermeasures. So things like planning vaccination campaigns, figuring out if we can get the forecasts to be granular enough spatially, figuring out how to better staff hospitals, free up hospital beds, free up ventilators, et cetera. Our group has had the highest accuracy forecasts every year except for the last year, in which case we had the second highest accuracy forecasts, and we became a center of excellence last year. So let me tell you about what flu forecasting looks like, and then I will tell you why it's so relevant to what is happening right now. So the most basic target that the CDC cares about is called ILI, influenza-like illness. And they care about the percentage, essentially, of visits to a hospital or doctor in the US, the percentage of such visits in which a patient reports these symptoms. So this is a clinical diagnosis. It's not confirmed by a laboratory test. And why do they care about this? This is believed to be a leading indicator of flu burden. So for example, if we see ILI go up, then we may believe that in a number of days or weeks, we'll see an increased burden in terms of hospitalizations. And there's lots of literature that supports this. This is the CDC's, at this point, kind of most basic unit of interest. And so what I'm plotting through here is national level ILI across the years 1997 through this year. So I actually generated this plot, maybe a couple minutes before we started. This is the most recent data we have in terms of influenza-like illness. And the CDC started doing this in 1997, so that's as far back as we go. And so you can see, of course, very clear seasonality as we go from year to year. This was the year of the 2009 H1N1 pandemic, and if you look carefully, you can see a very different seasonality. And at the very end, you can see what's happening this year, and if you squint carefully, you can see that we have a very abnormal behavior in terms of ILI, and I'll kind of revisit that in just a couple of minutes. So some notes, the CDC collects ILI at the state level, not just nationally, but for each state. Importantly, every data point that we get from the CDC is 1 week old. It's available weekly, but it's dated by a week because of a delay that kind of, the CDC takes to aggregate and collect and release the data. And the data is subject to revisions, so sometimes significant ones, because doctors turn in, let's say, reports late, and this is actually informative. It's not a missing at random type process. So why does the CDC care about ILI? Here's another way to look at it. If you think about the severity pyramid, and this is a CDC figure, then this is getting at syndromatic illness or symptomatic illnesses, this syndromatic surveillance. And there's obviously a clear relationship between that and hospitalizations and deaths. And so, of course, observation is important at every level of the pyramid. And you might imagine that the pyramid is actually much more complicated than this for flu. And it's significantly much more complicated than this for coronavirus, which is what I'm going to get to in just a minute. So let me tell you about what specifically we forecast. We forecast for the CDC the next 4 weeks of percentage ILI in every state. We forecast long-term targets, which is when is the worst week going to be and what is the peak value of percentage ILI going to be and how long is the season going to last. And predictions are repeated every week as the data comes in. And we do the same for hospitalizations. So this is currently what the kind of CDC flu forecasting challenges look like each year. So how does forecast seasonal epidemics? Let me just give you some very high-level points. I'm trying to convey somehow why none of this is appropriate for pandemic forecasting. So this is kind of the point of contrast I want to make. So first, you have to choose a model class, and the two basic classes of models are mechanistic and statistical models. The difference is that mechanistic models try to model the underlying kind of latent mechanism of the disease, typically based off of kind of epidemiological differential equation models. Like the simplest one would be the SIR, or susceptible, infected, recovered model. Statistical models model observables, so they don't deal with latent variables, at least not those that are kind of have biological meaning, and they're kind of a direct phenomenological model of observables. So our group works on statistical models, and I'm going to mostly comment on what kind of epidemiological forecasting will look like for those. Some of the key elements are to collect lots of data and proxies like what I would call digital surveillance data, which is similar to things that were mentioned by previous speakers. Flu near year, for example, as John Brownstein mentioned, would be like a terrific proxy.
1 minute.
And some other keys are that you have to really kind of carefully handle non-stationarity because each season is a little bit different. So let me tell you why none of this is appropriate for forecasting a pandemic, and I'm sorry I'm running out of time. The kind of key element here is distribution shift. So what we're observing now is nothing like we've observed with historical flu, and by definition of the pandemic, it's nothing like what we've observed, period. And so what not to do is just to kind of continue to run the same forecasting systems. And so the CDC pulled the plug on the forecasting challenge this year, just started a new challenge in which we predict the same targets, eye-line hospitalizations, because the simplest clinical picture of coronavirus meets the kind of same clinical picture as flu. So let me tell you about the current landscape. I'm running out of time. The current landscape is that the CDC has continued the forecasting exercise this year, has just switched essentially over to focus on coronavirus, but considering the same targets. And the two centers of excellence, ours and another one, are helping kind of serve as advisors to this effort, in which we are building an ensemble of community forecasts from about 20 teams that are participating. One of the hardest things we're facing this year is the kind of requirement of using counterfactual reasoning. So we want to kind of ask models to escape confounders and produce scenario projections, which is going to be extremely important for policymakers. So my very last thing I'll say is that what you can do is that you can take symptom surveys like the one that John Brownstein mentioned and any of the ones you see, because we actually really value that data. And you can join in our crowdcasting effort, which is separate from what I've talked about, but I've put a link there. So thank you, and I'm sorry that I ran close to overtime.
Thank you very much, Ryan. That was really interesting, and it's good to see the repurposing of previous efforts for the current challenges. Our next speaker is Tina White. Tina is at Stanford, I believe a PhD student, and she's going to be talking about a mobile app intervention to slow COVID-19 using crowdsourcing data. You've heard crowdsourcing in the previous talks, so Tina will be telling us more. Thanks, Tina.
So my background is machine learning, and I'm a PhD candidate at Stanford. And to give a little bit of context for the intervention I want to talk about, I just want to mention when it first came to mind for me was just seeing news like this and becoming concerned that the kind of quarantines and the situation in China was something that could easily come here. This was towards the end of January, and just getting personally worried myself about it and sad to see the level of quarantine that was there in a city that was larger than, more people in it than the Bay Area. So that's when I first became concerned. And then a couple of weeks later, seeing this article about China's coronavirus tracking app. I think this is what concerned me the most, were the details of this app and how invasive the app seemed from its description. So there's a lot of data collected about individuals that perhaps in this country would not be accepted or might be considered an infringement on civil liberties. So this is what concerned me, is that, well, perhaps we'll see these unprecedented quarantines here, and perhaps we'll also see apps like this here. So I became worried about that and started thinking about whether there's a way to perhaps perform a similar intervention as the kind of app that China came out with, but without infringing on our civil liberties. So that was kind of the challenge that I started thinking of around the time that I saw this article early February. So the first thing that comes to mind when you think about crowdsourced data is usually GPS, because everybody knows they have GPS on their phones, and those phones, these GPS is enabled. So that's the first thing that I thought of and wrote a post about, well, maybe there's a way to anonymize GPS well, so you're not sharing too much information about a person unnecessarily in order to create an app like this. And I also want to talk a little bit about what this kind of app does. So background a little bit in why this intervention is effective. So the kind of app that China came out with appeared to be doing a form of contact tracing. So if somebody is ill, the app will tell them, tell their close contacts or somebody that they've been in contact with recently. It'll send an alert, and then authorities will be able to get in touch with that person from that alert. It's sort of unclear what sorts of data they were using, but it looked like it was coming from all kinds of sources like surveillance, cameras, GPS, things like that. So this seemed very invasive to me. However, it did seem to be a very effective intervention. So there's this difficult choice to make at that point, because you want to save lives, but you also want to be careful not to infringe on civil liberties if you don't have to. So what we found after a while of getting feedback from people in public health and epidemiology was that GPS data is very identifying. So trying to collect that, it would be hard for us to do. If you connect it with medical data, our laws and regulations in the US are very protective of this kind of information, which is a great thing. We have much higher expectations around privacy here, and I have high expectations around privacy, and I'm glad that these regulations are still out there and exist. And so it was interesting to come up against this and try to think about, well, is there another form of intervention that will still work, but that doesn't collect this kind of identifying information? And around this time is when we ran into another group who was thinking about the same issues, and they had a little bit more experience than we did in the past. So they developed a flu tracking, or had been developing a tracking app for the regular flu, just like the last speaker had originally was doing forecasting for the regular flu, and now we're looking at COVID-19 data. So what they were using was a Bluetooth protocol in order to determine close contacts for the regular flu. And they had interesting arguments for why it would be a better way of measuring close contact between individuals. And that got us excited because Bluetooth communication occurs locally between devices, which means that there's a way to construct the system to be decentralized, and therefore the information that you gain from Bluetooth can be separated from identity before being uploaded to a database. So you don't need to collect any identifying information about a person in order to perform the kind of intervention, the same kind of intervention, but if you use Bluetooth instead of GPS. So this got us very excited. So Bluetooth is also a really good measure of close proximity between individuals, because the way to tell whether somebody is in proximity is a local communication between the phones, rather than being a communication that goes up to a satellite and then back down. And then you have to look at whether two trajectories are close to each other. So you have to put that on a central server somewhere in order to do that computation of who's close together. That's not true with Bluetooth. You can just, the two phones can know whether they're close together.
1 minute.
So we got very excited about this, and Bluetooth also, the communication is reduced if there's a wall. So in places where you're more likely to become infected, like indoors or inside of cars or public transit, it works a little bit better, or we expect it to work better than GPS. So I'm going to skip forward a little bit. This is our privacy model. This is the way that we can upload these numbers without actually uploading them with identifying information. We use a number called the CEN, the contact event number, in order to do this. And we also have a video of, we actually created this intervention in an app. So we have Bluetooth communication working between Apple and Android devices. We don't have time to talk, so I only have 1 minute left. And we worked with several other teams to try to implement this system, and several other groups are working with us now trying to develop Bluetooth as a technology. And finally, we have a few design images of what an app like this might look like. What we really wanted to share is this picture in the middle of our GitHub, where we've made everything open source, so any other country or that wanted to use this kind of protocol could easily pick it up and share it. They don't have to use our app, they don't have to use our logo, but just trying to make it easy for this intervention to be used anywhere.
Thank you very much, Tina, for an exciting project in the works. We're next going to go to Xavier Amatriane. Xavier is at cureai.com, co-founder and CTO, and he'll be talking about AI for COVID-19, an online virtual care approach.
Thanks so much, Russ, for the introduction. I'm really grateful for the invitation to the conference, and also humbled to some extent represent many, many startups that have poured their hearts and souls into addressing this crisis situation and working on coronavirus-related things. Now, also, sorry, I wanted to mention two people, because if this was a regular conference, I would have them on the stage, but the logistics are complicated. Both Jeff So and Anitha Kannan have helped tremendously in a lot of the research that I'm going to be presenting. Jeff So is our head of clinical informatics. He's also an assistant professor at Stanford in the Department of Primary Care and Population Health, and Anitha Kannan, who is our head of machine learning research. Now, before I dive into some of the COVID-related efforts, let me add some context about what we're doing at CureAI and what I'm talking about here. I'm sure most of you will agree that there were big inefficiencies and deficiencies in the healthcare system that were well known before this pandemic, right? And those include things like lack of accessibility to healthcare services, physician shortage and burnout, medical errors. Now, COVID-19 has not only exposed, but also augmented all these shortcomings, putting a huge stress in the whole medical system. Now, that has motivated many to propose telemedicine or telehealth as a solution. But the reality is telehealth by itself only solves some of the problems. In fact, telehealth is mostly a different medium for the same processes and practices. Very importantly, it does not scale or improve quality by itself. In fact, scaling telemedicine through AI was exactly what we were working at CureAI when this crisis broke out. So we decided to put our efforts into coronavirus-related features. Now, what is the solution that we're proposing? We are proposing an end-to-end medical platform that is always on, accessible, and affordable, and where we combine latest technology, AI, and automation, of course, and providers in the loop to accomplish both scale and quality of care. And we design our system to be always learning from the data and to operate in the wild. How does this look in practice? Well, as you can see here on the screenshot, and on the left, you see the patient client, the one that you can download and install in your phone or use from our web. And on the right, you see the provider client. And it is primarily a chat-based application that allows for synchronous and asynchronous communication. And there's an end-to-end integration of AI, both in the patient-facing and the provider-facing application. The provider tools might sound familiar to some doctors in the room. They include sort of like a new generation EHR built on top of the well-known FHIR standard, but includes full-on automation and decision support. And the platform, as I mentioned before, is designed to capture data and improve and learn over time. Now, going into what we've done for COVID-19, it includes a lot of different AI power features that I will just try to summarize in the following slides. Let's start with our automated diagnostic assessment. This diagnostic assessment is based on the latest known recommendations and research as of today. It's constantly being updated. On the surface, it may look like some other COVID symptom checkers out there, and I know some of them have been referenced in the conference already, but there's much more to it. One of the things we have is this is a dynamic questionnaire that adapts to responses in the flow. For example, in the third screenshot, you see that if you answer that you are a healthcare worker, then you will be asked whether you've interacted with patients with COVID-19. And the assessment is also based on personalized features, including, for example, when we're asking on the fourth screenshot, the zip code, this is including the latest known incidence of COVID-19 in the area. But most importantly, this automated assessment offers the opportunity for the patient to then continue the conversation with medical providers, both health coaches and licensed MDs, to address any need. And this goes all the way to actually final diagnosis and a care plan, as you can see here on the third screenshot. We also include automated and personalized daily follow-ups, so we keep checking on the patients over each consecutive day. What we're still working on, there's more features. One of them, very important, we have already added at-home testing capabilities to our platform. We are unfortunately still waiting for the FDA to approve. And we're also in discussions with existing healthcare systems who are thinking about using our platform sort of like a front end to their own healthcare systems. Okay, so I've talked about some features that are already in the product, but since we started at Curai, we have strongly focused on research. And we've done research in medical diagnosis, NLP, image processing. Here's a highlight of some of our peer-reviewed publications in the last couple of years, some of which have been in collaboration with Stanford and also MIT. And now we are applying some of that research to COVID-19 scenario. As a first example, in one of our previous publications, we used a double fine-tuned BERT language model to identify similar questions. The pre-trained language model was fine-tuned on a medical Q&A task and then on medical question similarity. We're now applying that with some slight modification to the COVID case. Now, why is that important? Well, we're implementing an automated question answering feature with the goal of providing a much better user experience to people looking for COVID-19 information. So instead of navigating through a long list of questions, the user can then input their personal question and be directed to the most relevant ones. Also, importantly, to avoid misinformation, all our answers are curated. And because a simple answer might not solve the concern or the problem, we again have the opportunity to connect directly with a provider. Okay, and finally, I'm also very happy to share that we have now trained what, as far as I know, might be the first machine learning COVID-aware diagnosis model. We have used the same approach described in our Learning from the Experts papers that you can see here. The basic idea is to use an expert system as a prior and simulator to generate clinical cases. Then the simulated cases can be combined with any other data, such as, for example, data from EHR. What we have done now is we have added data coming from our COVID assessments in the product. This is a great example of the ever-learning feedback loop that I mentioned earlier. And now we have a fully COVID-aware diagnosis model. Of course, at this point, it is hard to evaluate the accuracy of the model just because there is no ground truth data at this point that we can test with. But we're very confident that this is going to be valuable and improving over time. And again, showcases how machine learning can be used from very early on to build these diagnosis models. So to conclude and highlight the main point of what I mentioned, healthcare needs to scale quickly now. The only way to scale while preserving or even improving the quality of healthcare is using technology and AI and automation. But AI cannot simply be dropped in the middle of all ways of doing things. We need to integrate it in an end-to-end system benefiting both patients and providers on both sides. Thank you.
Thank you very much, Xavier, for that exciting vision for where we need to go. Our next speaker is Mark Musin from Stanford University. Mark is going to speak about knowledge technology to accelerate open science in addressing the COVID-19 pandemic.
Thank you all, and again, thanks for the opportunity to be here. There's been a lot of discussion in the lay press about how the COVID-19 pandemic is going to change a lot of features of society. One element of society that actually hasn't been discussed a lot is that COVID-19 is going to change science and the way we do science in some profound ways. And what I want to talk about today is how some of the work we're doing at Stanford may be helping to push that change forward, particularly in the context of the current epidemic. And now I can't advance my slides. There we go. I'm sorry. the main thing I want to have you take away is that science in the past 10, 20 years has changed radically as people are recognizing the importance of making available online the very data that scientists are using to form their hypotheses and to publish their papers. That there's been a shift as we recognize that the output of science is important, not just in terms of publications, but in terms of basic data, so that other scientists can go and look at those data, can verify that the results of the experiments are correct, and also can take those data and reuse them and potentially make new discoveries. And nowhere has this been more important than the case of the COVID-19 epidemic, where suddenly all these data that are filling up resources all over the world with information about COVID-19 suddenly are available, and people want to be able to have access to them quickly, want to be able to use other people's data to make new observations. And there's just enormous excitement about the whole idea of open science and the opportunity to take advantage of data that already exist to be able to make new observations and hopefully to address the epidemic. That's all the good news. The bad news is that although we have lots of data out there, it's kind of like having a library where you don't have a good catalog, where you don't know where all the resources are, where you can't actually easily find what you need to find. And so the scientists who are most interested in being able to find other investigators' data and learn from them are kind of stymied. And they're stymied for a reason that's going to sound rather arcane. They're stymied because they don't have good metadata, the data that describe what the data sets are all about. Let me just show you why I say that. In this, first, let me just emphasize that the buzzword that has become so frequently used now to describe the problem is the idea of trying to make data that are fair, that are findable, so you can actually search for them, that they're accessible, that even once you find the data, you can actually download them and look at them, that they're interoperable, that you can take your data and mix them with my data, and we can actually get something better than the sum of the parts, and that the data are reusable so that they're explorable by others. So this buzzword of having data that are fair pervades biology right now. And the challenge, as I said, is that most data are not fair. So here are the metadata, or a tiny piece of the metadata that describes samples that are in a repository at the NIH called GEO. And these results show you in several records how scientists have described the age of the patient, from age to age to age to pop age to age after birth to age in years to God knows what. If you're a scientist and your goal is to find a specimen that's described in a repository where you want to look at the data that were accrued from some experiment, you have to know what to search for. And if you have to know, and if you're interested in patients of a certain age, you have to know how the investigator might have chosen to represent age in one of a million different ways, including a million different typos. We looked at a repository called Biosample, another NCI repository, and wanted to really quantify how bad are the metadata, which means how bad and how difficult is it to search for someone else's results. Well, 73% of the Boolean metadata values are not true or false. They're values like non-smoker or former smoker. 26% of the integers don't parse as numbers. And 68% of the metadata entries that are supposed to represent terms from standard vocabularies, well, are not terms from standard vocabularies. And what that means is if you're an investigator and you're trying to find a particular set of data, you're often really stuck because the metadata are terrible. And why is that important for COVID-19? Well, if we want to find relevant studies, if we want to be able to integrate new results with those that are already available, if we want to re-explore existing data sets, if we want to verify published claims, we may have a lot of difficulty finding the right answers. And one of the things that I find remarkable is that just in the past couple of weeks, there's been this absolute flurry of activity in the COVID-19 community demanding that we get data that are available and that are more fair, data that are more accessible, data that are more reusable. And the question becomes, how can we actually come up with better data like that when, frankly, the data that exists online are very difficult to search and very difficult to use? Well, like many other people in this session, we have technology that we're trying to repurpose specifically for COVID-19. We have technology we've created at Stanford called CEDAR, where CEDAR is the Center for Expanded Data Annotation and Retrieval. And CEDAR basically offers a three-step process where initially we author metadata templates. We decide for different classes of experiments, for different kinds of experiments in virology, in biochemistry, and whatever, what are the kinds of experiments that people do? And can we come up with a way of standardizing what the metadata for such an experiment should look like? We then have a mechanism within CEDAR that allows us to annotate those templates. We basically fill in those templates with terms from controlled terminologies that are consistent with well-defined data types. And ultimately, that gives us the ability to take the metadata that we enter into CEDAR and use those metadata to annotate the data sets that are stored in the repositories that investigators ultimately want to explore.
1 minute.
One of the things we also do is to look at those data so that we can easily use those data to make it easier for people to fill in the blanks of the form. So for example, here's a form for filling in information about a specimen for a repository called biosample, and the drop-down menu gives you all the controlled terms that might be appropriate for the tissue. However, if we want to look at what the disease might be, if we already said the tissue is lung, then because we know a lot, we can use AI and say, well, look, we don't need to provide all the possible values. We just look at lung cancer or chronic obstructive pulmonary disease or other kinds of conditions that might be associated with lung tissue. If we say the tissue is brain tissue, then our menus can be much more simple, and we can specify, for example, what are the kinds of diseases that might be associated with a tissue coming from brain. What that means is when we create metadata, we don't deal with the mess that we currently have, but rather we have metadata that are really tailored for the situation and that use the kinds of terms that people want to search for. In the past couple of weeks, the Go Fair organization, the people in Europe who are promoting the FAIR principles in the strongest way, have created something called the Virus Outbreak Data Network, or VODAN. And one of the things that VODAN is doing is using technology such as CEDAR in order to be able to make it easier for investigators to create data related to the epidemic, data related to virology, data related to all the kinds of experiments that people need to do in this area, and make this data more readily available. We know that data are never going to be fair unless we have common templates, when we have controlled terms, and we have technology that makes this all easier. And so what gets us very excited here at Stanford is the ability to take our existing technology known as CEDAR and to repurpose it for the purpose of making it easier and faster and more reliable for workers in the COVID area to be able to get the kinds of data sets they need in order to do the kinds of analyses that they view it to be most important.
Thank you very much, Mark. And I'm just struck in this session by how many people have pivoted their organization and their efforts to be relevant and useful for COVID. It's quite inspiring. The final speaker of our session is Johannes Eichstadt. He is from Stanford, and he will be talking about what can we learn from Twitter analysis about COVID-19.
Hello, everyone. My name is Johannes Eichstadt. I just joined Stanford faculty. I am a psychologist, and I specialize in using social media to understand the psychological states of large populations. And today, what I thought I'd do first is to zoom out a little bit after so much disease focus to try to capture a little bit of the psychological impact that might be coming our way. So if we think about the COVID-19 outbreak and everything that happened around the outbreak, the social distancing, there's probably three main things that are going on. Right now, we are all going through a phase of uncertainty and anxiety. This came up in previous talks. There's an acute adjustment phase where we're engaging in information searches that serve both informational and psychological needs in our sense-making processes. This is an acute adaptation process. Then there's going to be a real low hierarchy of needs impact on a large part of the population. That's unemployment. There's a huge unemployment shock. And then there might be the biggest transition in social norms, rituals, and behaviors since World War II coming our way as we're transitioning from face-to-face interaction to the digital space. Humans are a fundamentally social species. A large part of our neural infrastructure is dedicated towards tracking other people, body language, human contact. We regulate our emotions better through other people than basically any other way. And we're now seeing a natural disaster unfolding in slow motion with an absolutely unpredictable impact long-term on our psychological adaptation. I think that's fair to say. So I think that there is a good chance that all three of what we call pathways will lead to reduced subjective well-being and mental illness. So just a quick check in on the unemployment, I mean, many of you, I presume, have seen this. This is data from the US. The gray area there is the Great Recession, 2008, 2010, spikes in unemployment up to 300,000 per week. This is just what happened last week, 3.3 million new unemployment claims. This is a shock to the labor market that we have not seen since World War II. So what do we know about the psychological literature of unemployment? So here's a famous study about 24,000 Germans that have gone through unemployment. And you see that they go from the baseline. You see 2 years before unemployment, and then unemployment happens at the 0 line here, and their life satisfaction, which is the sort of one of the key variables of subjective well-being, drops by 0.7. Okay, what is 0.7 on a 10-point scale? Doesn't seem like that much. Here's context. So here are national rankings of life satisfaction, which is heavily dependent on income and education, all the things we value in society. And going 0.7 down in these statistics would mean going from the United States to Slovakia or Uzbekistan. That is just the impact of unemployment. So if we go back to this model and we just think about this pathway here, it is huge. What about loneliness, this piece down here? Well, this is a study of 700,000 people. There, the impact of loneliness is 0.5, so almost as much as unemployment. And it's comparable to the impact of suffering from headaches or being chronically ill. That's also big. So if you look at this whole model, right, this pathway is big, this pathway is big. How lonely are we going to get as a function of this outbreak? I think that's up to us. That's up to us, to our ability to transition into the social, digital social spaces beyond FaceTime, find new ways of belonging and connecting in the digital space. And finally, the uncertainty anxiety piece, that's hard to predict. So if nothing else, we as social scientists, we as people who care about the public health of the population, need to measure the well-being of the population at scale, now more than ever. How might we be able to do this? Well, my colleagues and I, for now 10 years, have worked on methods of using Twitter to read the language of communities across the US and across other countries in the world and create well-being estimates. And we're doing that now, and we're going to try to make that data available as quickly as we can to the entire research community, so we can start figuring out how our psychological experience is changing now that our biological experience has suffered this impact. So we're collecting fresh data. But what can we learn from Twitter in the meanwhile? And this data is fresh. It's still warm. What we did here over the last month is scrape Twitter for hashtags, clean it, throw out replies and retweets. Then we extracted something called topics, which are these clusters of coherent words. I'll show you what those are in a second. And then we combine it with other things that we knew about counties, including the cases and the confirmed deaths and everything we know about the census and who lives in these counties. And then we just looked in this data space of what kind of connections can we see and how people talk about the disease and what these communities are structured like. So the first thing here that I'm showing you is what's going on right now in urban counties across the US, right? So this is probably wherever you're watching from, this is probably where you're watching from. So you see a lot of this adaptation. So all these clusters are little pieces of language that COVID-related language that hang together. So these things are all significantly correlated with living in urban areas. And you can see this adjustment to COVID lifestyle, from not touching your face to there's panic buying and toilet paper here in the middle, to things being canceled and working from home. In a sense, this is the adjustment, right? Just a functional adjustment. If we look at this slightly differently and we look at this data by education, we see that educated areas are very information seeking and information processing. So there's a lot of talking about articles and news. There's, of course, things that will be canceled in the future, like conferences or move to the digital. There's talking about testing, about healthcare, and about government reaction. So this is high-level meaning making and information integration. How does this look like by age? Well, in older counties across the US, there's talk about Trump and about the economic impact. Whereas in younger counties, this is much more problem-focused coping. This is the one language cluster that stands out there is that in counties that are younger, people talk about washing their hands. And finally, if we actually look at who voted for Trump in the among the counties, the one piece of language that stands out there is this, it's just like the flu. It's the sort of downplaying conspiracy talk. And we're starting new research now where we see how this sort of misinformation decays. Presumably everybody is being slowly ramped up onto the same reality. And finally, what do people feel most negatively about right now on Twitter? They feel scared, they feel negative about the economy, and then there's a huge cluster of feeling negatively about Trump. So here are my very quick takeaways. We really need to measure the well-being impact of COVID, both the entire distribution of risk, well-adjusted people, people who are in danger of mental illness, and we very quickly need to think about scalable mental health care. And now is the time to mobilize resources to make that happen. We see sign of COVID adjustment in urban educated communities. We don't yet see it in rural areas. I think that's coming. The biggest predictor right now of COVID cases is still population density, so that makes sense. So I guess we're just a little bit ahead of the curve there. And finally, there's a huge promise in using the unobtrusive data, the digital exhaust of our digital spaces, to monitor progress week by week. And other speakers have spoken to that as well with things like location tracking. Twitter allows us to also do this in the psychological domain. Thank you very much.
Thank you very much, Johannes. That ends our session talks, but now the fun begins with respect to our panel. So I'd like to ask all the panelists to turn their video on. This will be our biggest panel of the day, so hopefully we will not stress out the internet. I'll give you, and I'm also welcoming Rob, my co-moderator, back. So thank you all, and we have a lot of questions from the crowd, but I want to give Rob the chance to kick off this session, and then we'll take it from there.
Great, thanks a lot. I've been listening with enormous curiosity here to look at the various ways that people have repurposed their research and various attempts to confront the crisis head on. I have a question about the variety of different things that were described, especially by the first 4 or 5 presenters, Jason, Lucy, John, Tina, Ryan, maybe Xavier as well, which try to predict the scope of the epidemic, as well as to provide diagnostic tools, even in the hand of your cell phone in your hand. Here's the question, though. My layperson's understanding about COVID-19 is that some of the most worrisome super spreaders are completely asymptomatic. So people who wouldn't, if given a cell phone diagnostic tool, answer yes on any of the questions with the symptoms, and yet they're some of the most dangerous people still to be out and about socializing. So I'm wondering if anyone can address how it is that interventions of any kind, other than physical distancing, sheltering in place, can tackle the problem of asymptomatic patients.
And let me just say, I see Xavier raising his hand. Let's use the good old-fashioned hand raise if you'd like to be on the list of responses. Xavier, you can go first.
Yeah, I mean, I think the real key here is how to keep people away from hospitals and actually keep people away from each other, right? So I think that's why I was saying in my presentation that telehealth and any form of telehealth that scales is a really key thing here. Whether you have symptoms or you don't, if you have a question and you need to talk to somebody and you need to talk to a provider or a doctor, and you want to do it from your home and you don't want people to leave their house, even if they want to get tested, right? So that's why at-home testing becomes so important. We only want people to leave their house and go to the hospital in really critical situations. And I think the symptom checkers and all these automated assessment tools are important if there's an ability to then follow up with the next steps. And I think that's the key message, right? How do we treat people from their houses without incurring in risk for themselves and for others?
Go ahead, Tina.
So I think to some extent, the intervention that we're proposing captures some of these events where you have asymptomatic transmission. Because if someone were to voluntarily put into their phone that they were a confirmed case, and then the people that they contacted are anonymously alerted, those people who were contacted would be instructed to stay home sort of a more targeted intervention, like you specifically ought to stay home for the next 2 weeks. And those people may or may not be symptomatic. So we would capture some of that with this intervention as well.
Yeah. Just to add, I mean, obviously, being able to identify even asymptomatic people is pretty critical. There's some interesting sort of studies out from companies like Oura, the Smart Ring, Whoop, the sort of Smart Band. Both some early evidence shows that you can actually detect physiological changes even if the person isn't experiencing symptoms. So some interesting opportunities around wearables and continuous tracking that ultimately can identify cases even for those that don't actually experience symptoms.
What kind of physiological changes do you have in mind there, John?
So like heart rate, temperature. I mean, they're identifying cases days ahead of someone actually experiencing the symptoms. So that to me represents a great. I mean, they're deploying these in certain populations right now, and with some really exciting results.
Ryan, and then Johannes, and then Jason.
I just wanted to speak to something that was very related to what you said, but it's at the next rung of the severity pyramid. If you think about the severity pyramid I mentioned, so asymptomatic contribution would be the bottom rung. The second bottom rung would be symptomatic contribution. We actually have a very poor national snapshot of symptomatic contributions at this point. So yes, I'm worried about asymptomatic carriers. I'm also worried about the fact that we do not have a surveillance system in place that at a low temporal latency and a fine geographic resolution identifies people who have symptoms. Now, there are many efforts out there, like some things that Jonathan mentioned. I'm aware of probably at this point 10 plus surveys that are web-based, people to report their symptoms. The truth is the sample sizes are just way too low. So I would say that I mean, an easier problem to solve is a symptomatic one. So a national or even international surveillance system at this point, which is capturing that, would be extremely useful.
Johannes, and then Jason.
Yeah, just a very quick point, purely from a data science point of view. As we're trying to capture these asymptomatic cases, I think it'll be critical to merge feature spaces from different data domains. So if we have Bluetooth interactions, Bluetooth proximity in conjunction with the annotation of people self-report that they have symptoms or that they've been tested, it's really a question of merging the density of these data spaces across domains so that you can cover up the holes that you have in one kind of data with the density that you have in another set of data. And that builds on the previous point. The goal here is to create a density of the datascape so that you can make these inferences.
Jason?
I just want to make a point that symptoms are subjective and signs are objective measures. So fever is a sign and not a symptom. So if you look at the reporting, there's the fever occurs at 80 to 90% of the individuals, and then there are other symptoms like dry cough and shortness of breath and all that. So if you take a lot of people here are working on collecting these symptoms and signs, can you build a prediction tool for us where if you get 3 or more or 5 or more or 6 or more, if you get everything on the list, and it's more predictive, because most people are going to have fevers with COVID-19 at one of those 14-day incubation periods. And so it's 80 to 90% of them.
Ryan, and then Lucy.
Yeah, I can speak to that. So first of all, I just want to emphasize that yes, symptomatic surveillance is not the same as positive laboratory testing, but the CDC currently adopts influenza-like illness as one of its gold standards for measuring, let's say, prevalence. So that is very clearly defined as fever of 100 degrees or higher, along with sore throat or cough. Now, you might think adding, for example, difficulty breathing, if you're trying to look at, kind of a very, very basic symptomatic presentation of coronavirus. But I just want to be clear that there are models then that take things like ILI prevalence and then predict hospitalizations, predict critical hospitalizations, predict deaths. And these models are very well established for influenza. The question is whether we can train them fast enough in a sense of, by fast, I mean, do we have enough training data to kind of make useful forecasts for coronavirus? But I agree with the basic point that symptoms are not kind of a positive confirmation of disease, but they are still extremely useful in terms of these projections. And they are very clearly defined in terms of how we consider kind of positive cases, at least for influenza.
Lucy?
So there are some modeling studies that show that people without symptoms are slightly less transmissible compared to those with symptoms. So they're not, sneezing or coughing. But if they're able to go outside and make more contacts with other people, then ultimately they might end up infecting similar numbers of people. So ensuring that even if you feel well, that you're not going outside except for like essential purposes will be key to keeping the case numbers low.
Thank you. Now I want to go to our the crowd has been our listeners have been very active, and our intermediate people have been summarizing. But there are a ton of questions from the listeners about whether the tech companies have data sets that could or should be shared that are not being shared. People mentioned mobility data, and many of these came up, but mobility data, phone data, sound and sound surveillance. I mean, there's a lot of Alexa devices that are listening to us and listening to me even as we speak. And social networks, we've heard about them all a little, but I'd like to know, are there big things missing, or are there big opportunities that we should be capitalizing upon? And again, show me your hands. John?
Yeah, I mean, listen, the tech companies have been incredibly collaborative. Like the COVID Near You project I presented is actually a collaboration across Google and Facebook and Airbnb. So a bunch of engineers are all contributing in time. So there's a lot of activity at the sort of the bottom up approach. At the top, yeah, I mean, mobility data sets, what I presented was Baidu, but also Google's releasing some data in this space. They're trying to go as fast as they can while still being under the same pressure that they've undertook over the last several years around data. So it's hard, would be hard to press to do some of the same types of sort of app-based approaches that we saw in Korea and Israel and other places without sort of really major sort of federal support. And I think that's where there's potentially a little bit of a disconnect between sort of what's happening at the federal government level and what they're trying to push in terms of an app-based contact tracing approach. But as far as like one-off data sets, I mean, and collaboration, it's been as great as I've ever seen at any point in time.
Great. Xavier, Ryan, and then Lucy, I wanted to ask you specifically if you're using these kinds of data in your modeling. So Xavier, Ryan, Lucy.
Yeah, I guess as a representative from industry here, I've been hearing this since the first session. I know Nigam Shah and Dr. Berry also talked about how hard it is to share data given some of the legal landscape, and that's a reality. I mean, if you think about many of the countries that Michelle Berry talked about where they had a successful approach to coronavirus, they had really compromised privacy and individual freedom and have gone all the way to sort of having drones measure temperature of people in crowds, right? I mean, that is tricky, and it's a really critical sort of like social discussion that needs to happen. And I think it's the same when it comes down to how much granularity of data can all these tech companies share, and to what extent that is legal and available. And I think Professor Shah was also mentioning that he had some difficulties accessing some of these data sets because of the legal landscape. And I think it's a great discussion to have, but it's also a very slippery slope. So like, how do we in a situation of crisis, how do we react quickly and also safeguard sort of like privacy and all these other freedoms that we have, right?
Ryan, and then Lucy. Ryan?
Yeah, this was touched upon, but I just wanted to make it explicit that so data privacy is, of course, one of the foremost issues people discuss today, and this is an unfortunate time for this to have been such a big issue, because there are real issues of privacy surrounding sharing of medical data. That being said, what we've seen in our group, and I think this is true across probably anybody who's working on COVID modeling and forecasting, is that there's been more movement and there's been more accomplished in the last 2 weeks than I've seen in years in terms of data sharing. So agreements that we've been working on for literally 3 or 4 years have now, in a matter of like days, been signed and finalized. So one thing that I've been doing with Google for the last 8 days, Google ran a trial period of a survey that was very, very simple, asking people whether they had ILI, influenza-like illness, which is fever of 100 degrees or higher, along with sore throat or cough. And this was sent to about 1 million people. Actually, in fact, more. I got about 1 million responses over the course of a week. So this kind of thing usually would take, a very, very long time to plan and to deliver. But I think companies are really willing to help. And I think it requires a giant like Google or another kind of really big tech company. And I think there are many others of these in the works to kingmate or adopt kind of one survey or one mode of surveillance and just make it available to everybody. I think that would be really beneficial to the entire community. And so we're working on making that happen. But.
Lucy and then Tina.
I think
Lucy, in particular, the crowd was wondering if you were able to incorporate these new data streams into your modeling.
So right now, we're not incorporating any of the social media data yet, but we would very much be interested in having access to more granular data than what is provided at the county and the state level. And I think one conversation we've had with people is that publicly only data down to the county level is available. So there's no information about how many people are actually infected in individual cities. So obviously in places where the city sizes are small, that could present a potential privacy issue. But in places like the Bay Area, when each city is a very sizable population, I think that needs to be a conversation that needs to be had to balance privacy, but also like informing the public about how many COVID cases are happening in their area. So in addition to getting access to these new streams of data, we're also interested in exploring how to safely share data with the public so that they can be informed without compromising confidentiality.
Yes. And Tina.
Oh, I just wanted to mention that our approach was kind of designed so that you don't have to collect identifying information about individuals in order to use it. So our data set in some ways is kind of special because there's no actual identifying information in it. It's just these anonymous contact event numbers, which are then deleted after a couple weeks and are only interpretable by the individual phones. So there's a little bit disappointing to researchers in some way because we don't have a data set that we could really perform research on. It's only information that is used to form this alert system. So it's only an intervention and not something that generates a data set, which is kind of what we were aiming for, something that's so private that we can't even like interpret it ourselves. It's only interpretable by the phones that were locally involved in the contact events.
Mark, did I see you twitch? No. Let's go to the questions. Let's go to the questions from the, some of these are geared towards individual speakers, and I think there's a lot of interest. So let me just go to a couple of them. One question for John is, how are these technologies like Buoy and the COVID Near You advertised to doctors' offices or the public to get buy-in on a massive scale?
Yeah, really great question. I mean, obviously, we're building off of the existing tool base. So we already have a cohort of 100,000 people in Flu Near You. So that gives us a jump start. And of course, leveraging social media, news media, and then our partners at CDC and public health departments, they're all sort of pushing it because local public health department pushing a COVID Near You, then all of a sudden gets granular data for their particular community. So creates a bit of a new channel for marketing. But we're still trying to get 1 million people in the system. We're a quarter of the way there. So still a lot of work to do to figure out how to get people engaged. Absolutely.
And just as a follow-up from me, and not necessarily from the crowd, is what is the best granularity you're going to be able to get? Realistically thinking, are we talking county, city, blocks? What's your thinking on that?
So our data is at the zip code level. Right now, the amount of data we have in the 260,000 reports, it doesn't give it the granularity other than say city level and state level. We start to go 10x that volume. I think we start to begin to have zip code level, data that becomes valuable for us.
Great. Another question. Sorry, Rob.
Yeah, I'm just going to hop in with one that also from the audience, but I would love to have some of the experts on the panel react to as well, which is that for those of us who aren't data scientists, aren't biomedical researchers, we're getting our information from the usual newspaper sources, Twitter or whatever. Various different places have become central repositories of projections. One of the questions that arises is why so few of the kinds of models that we ordinary people are reading have any uncertainty intervals attached to them. We always get projections of lines that go out with no uncertainty intervals, no information about the confidence about the projections. So I'm wondering, for those of you who are making some of these models, how would you respond to audience questions about why so much apparent certainty in the public communication when anyone who's a social scientist, a scientist, knows there are some uncertainties built into the projections?
Ryan?
Go ahead.
Yeah, I think that's really unfortunate, first of all. I suppose I've seen it both ways, to be honest, in terms of news coverage, but it is unfortunate that there are projections made that don't have uncertainty kind of quantification attached to it. I just want to make clear that within, I think, the CDC's view of forecasting, which I think is a model that's adopted by lots of local public health officials as well, we look at forecasting distributions, not targets. So for example, if you want to know what is going to be the worst week of the year between now, of the season, say between now and December, that's a distribution we're putting forth. So each week I'm going to assign some probability I think it's going to be the worst. So those are fully kind of, let's say, probabilistic. And uncertainty can be gleaned directly from those. So in terms of the forecasts that I think most of the community is making, at least, there are probabilistic. Uncertainty estimates are kind of baked into them. If those aren't being reported at the level of kind of presentation in various news outlets, I think that's really unfortunate. One thing I will say is that some models actually do not lend themselves as easily to these types of uncertainty estimates. And it may well be that particular types of models which are based on maybe more mechanistic kind of transmission type approaches are being presented in the news, and therefore it's kind of harder to read uncertainty estimates from them.
Good. I saw Xavier also want to get in on that.
I have a different hypothesis. I think that it's really hard for the non-experts to deal with uncertainty in model predictions, right? And that's why you see those uncertainties that exist not being reported, generally speaking, to the main audience or the main public. Now, if you think about it, even very early on, there were some models that were predicting anywhere between 100,000 and 4 million deaths in the US, right? And that felt to most people that don't know anything about modeling like pretty much noise, no information. Like what's 100,000 to 4 million? That's a huge. But the reality is, if you have an exponential and you have some uncertainty on the slope, that's where you are, right? So dealing with that level of uncertainty for the general public, I think it's really hard, and therefore journalists and many of us tend to just avoid it and just go for the middle of the projection and say, okay, it's roughly going to be around that. But that's probably a statistical lie, right?
Mm-hmm. I want to go to another question that's coming up in the crowdsourced questions a lot, which is a lot of the technologies we've been discussing today are more prevalent in younger demographics. And yet we know that the older demographic is not only at greater risk, but has less access to some of these technologies. So there's a general question about what, if anything, are we doing to make sure that these solutions we're addressing are relevant and serve the interests of the less technologically capable and folks in society? Tough question. Johannes?
Yeah, so this comes up a lot in sort of different pieces of this research puzzle. The truth is that it's all a question about sample size, right? So as long as we have a substantive number of younger people in the population that can represent a particular population, a county or a city, we are then able to make inferences around those people who are at risk to whom it might be spread. I would also like to say that people tend to grossly misestimate the age distribution of digital technology. So the age difference between the median age of Twitter and the US population is 5 years. It's not 15 years. So it trends a little younger, but not by much. So all of this comes down to just having big enough samples and being good in your statistics. But for a phenomenon that is fundamentally about community contagion, having any member in a community is incredibly worth it.
Jason?
Yeah, I wanted to say that, some of the technologies send out passive data, and others you have to do active data. So for the elderly, it may be more appropriate for a bracelet or something that sends out passive data to whatever you're trying to track.
Jason, I wanted to follow up with another question that came in for you, which is how significant is the different way that healthcare is set up in Taiwan for their somewhat stunning success in managing? I believe they have universal health insurance, and it sounds like there were bracelets and all kinds of things, either pre-distributed or quickly distributed. What can you tell us about the differences in the healthcare system that might be pertinent and that we might want to think about implementing in other countries, including the US?
Yeah, so national health insurance is nice, but is not why they're successful. Because in Palo Alto, we could easily get patient data and triage patients. We could easily make an app and say, tell me these symptoms so I could triage you, not through the ED, but through a fever clinic. If you have travel history, I'll triage you differently. So we have all the technology here in this country, and we have more. So I would say that it's nice to have, but not must have a national health insurance system. The other thing is that they were prepared because they had all these laws that allowed them to do certain things, and then these powers expire. For example, they expire in a year from March. So because you have all these laws, you were thinking ahead, then you could say, okay, who's the honest broker here for these data? And then how do we quickly get all the data in the same place so we could use it? And let me give you an example. In the immigration and customs data set, they send batch file to the National Health Insurance Program. Not all the travel history, just the travel history in the last 14 days. And then after that, they just get rid of it. So there's a way to clean the data out so that you're not there forever in terms of your travel history. So that's just one example.
And then for Ryan, there was a question about, you made it very clear in your talk that I think the word weird actually might have even appeared on your slides. So given that it's so weird right now with COVID-19, what's the source of your confidence that all the great work that you've done with flu will translate well and usefully to COVID?
That's a good question. I guess it depends on what targets you're talking about. So I have very little confidence at this point in long-term forecasts. And in fact, I am not a proponent for making forecasts past 4 weeks. So our group in particular has been pushing to kind of get rid of long-term forecasting for coronavirus. But I think it'll continue, but I just hope that we don't end up conveying a lot of that, because I really don't trust, aside from the uncertainty kind of levels being massive, I don't trust long-term forecasts at this point for a variety of reasons that don't have anything to do with statistics. What happens past 4 weeks is going to be dictated in such large part by policy and by adherence to policy that it really does not make sense to me to be pushing forecasts past that. That said, a lot of people care about long-term forecasts for a variety of reasons. So my answer is kind of convoluted, but if we can get access to the data that we're hoping to get access to, which would be a game changer for us, which would be national level surveillance data of symptomatic illnesses, and we can get access to hospitalization data that we're seeking, then I have some confidence that we can make useful short-term forecasts. Now, I'm not positive we're going to be able to do this at the county level. You mentioned geographic granularity earlier. At this point, we're aiming for the county level, but we may not be able to do so given the sample sizes we're seeing. We are seeing, I think, the largest sample sizes possible in some sense with these data sets. And we may have to kind of fall back to health market area, which is, it's a combination of counties that are dominated by one health market. So that might be something on the level of a metro area. But that's the hope, at least. Short-term forecasts, metro area within 1 to 4 weeks.
Thanks. Well, you know what? Our panel is coming to a close. I want to thank you all for your work. I'm struck by the pivoting, as I said before, of many organizations towards COVID-19. But at the same time, the downside is the requirement that we all pivot is probably costing us something. And there was breathtaking examples in earlier sessions and in this session hearing about Taiwan of how much preparation helped in other places. So pivot is great. Preparation is great. I want to thank you for all of your work. We will resume in a short time with the final session on treatments, vaccines, and the patient experience. But for now, thanks very much to the panel, and we'll see you back in a short time.